Heart attack, the moment when heart muscle starts dying because blood flow suddenly stops. Let's break down what actually causes it and how it shows up on ECG. Most heart attacks happen when a plaque inside a coronary artery ruptures and a clot suddenly blocks blood flow. That's the classic mechanism. But the story isn't always that simple. Sometimes the heart just runs out of oxygen without any blockage at all. For example, during severe hypertension, arrhythmias, or shock. A spasm or a small embolus in a coronary vessel can do the same. And in rare cases, the heart stops so abruptly that there is no time to record an ECG. And that's sudden cardiac death. And occasionally, myocardial infarction can happen when a thrombosis develops where a stent has been placed or from accidental injury during bypass surgery. And when we suspect an ongoing infarction, the ECG becomes crucial. It's fast and cheap and tells us what part of the heart is in trouble. We always pair it with cardiac troponins, which confirm actual muscle damage. The coronary arteries rise from the base of the aorta and wrap around the heart like a crown. We've got two main ones, the right coronary artery and the left coronary artery. The left coronary artery quickly divides into two major branches, the left circumflex, which supplies the lateral wall of the left ventricle, and the left anterior descending artery, which supplies the anterior wall and the septum. When the left coronary or its branches are blocked, we see anterolateral changes on the ECG. Now, the right coronary artery supplies the right side of the heart and gives off a branch called the posterior descending artery. A blockage there leads to a posterior infarction. Inferior infarctions, on the other hand, can come from either a blockage in the left circumflex or in the lower branches of the right coronary artery. Let's now get an idea of how the chest leads relate to the heart. V1 and V2 look through the septum, while V3 and V4 capture the anterior wall. Together, these leads reflect the area supplied by the left anterior descending artery. V5 and V6 sit further to the side and shows the lateral wall, which is supplied by the circumflex artery. By seeing which of these leads show ST elevation or depression, we can tell where the infarction is, septal, anterior, or lateral. Now let's look at the limb leads. These leads give us different angles around the heart. Lead 1 and AVL look from the left side and they show the lateral wall. Lead 2, 3 and AVF look from below and give us the inferior view. And lead AVR points toward the right upper side of the heart and mainly serves as a reference lead. Now that we have seen how the ECG leads correspond to different parts of the heart, let's look at how infarctions appear. In myocardial infarction, we see ST elevations in the leads facing the affected area, while reciprocal leads often show ST depression, which can appear as either horizontal or downsloping ST depression. An inferior infarction affects leads 2, 3, and AVF, with reciprocal changes in the anterior and lateral leads. A lateral infarction shows up in leads 1, AVL, V5, and V6, with reciprocal changes in the inferior leads. An anterior or anterolateral infarction involves lead V1 to V6, AVL, and lead 1, with reciprocal changes in the inferior leads. Now, lastly, for the posterior infarction, you won't see classic ST elevations. Instead, you might find ST depression and a tall R wave in V1, which can suggest a posterior myocardial infarction. To confirm it, we place additional posterior leads, which are called V7, V8, and V9, and can directly view the posterior side of the heart. When blood flow to part of the myocardium stops, the ECG starts to change and it happens fast. Within the first few hours, we see hyperacute T waves, tall and peaked, as the earliest sign of ischemia. This is quickly followed by ST segment elevation, showing acute injury. After 24 hours, the ST segment begins to return toward baseline, while the T waves inverts. That marks ongoing recovery, but still active damage. And as the infarction evolves, deep Q waves appear, and this is a sign of irreversible necrosis. Now, any deep Q wave, except a lead AVR, is considered pathological and usually tells us that a myocardial infarction has already happened. In this ECG, we can see clear ST elevations in lead 2, 3, and AVF. That's the classic pattern of an inferior myocardial infarction. We also notice reciprocal ST depressions at lead 1 and AVL, and subtle changes extending into V1, V2, and V3. In this ECG, we can see ST elevations at lead 1 and AVL, which point to involvement of the lateral wall. There is also marked ST elevations at lead V2 through V6, showing that the anterior wall is also affected. Together, this pattern represents an anterolateral myocardial infarction. We also see ST depressions in lead 2, 3, and AVF. Thank you for watching. I hope you found this video helpful and learned something new. If you enjoyed it, don't forget to like, subscribe, and share it with someone who might find it useful. See you in the next video.